Good morning, everyone. Today I'll be presenting a unique case on waxing and waning pattern of choroidal granulomas. So basically, the choroidal granulomas can arise either from the infectious or non-infectious causes, which making accurate diagnosis essential due to its different therapeutic approaches. The three main granulomatous conditions kept in the mind during diagnosis of choroidal granuloma mainly includes VKH disease, sarcoidosis, and tuberculosis. So, why accurate diagnosis matters? As misdiagnosis may lead to inappropriate therapy, like administering corticosteroids in presumed VKH when TB is actual etiology, may result in systemic dissemination of infection. So, the aim of our case was to present a unique case showing waxing and waning pattern of choroidal granuloma. A 28-year-old previously healthy female presented to ophthalmology department with chief complaint of both her diminution of vision since 4 months, which was associated with mild pain and redness in both the eyes. There was also history of dyspnea on exertion 6 months back, which was associated with fever, weight and appetite loss. So on further examination, the best corrected visual acuity in the right eye was 6.9, in the left eye was 6.18. The intraocular pressure by mean of non-contact tonometer in the right eye was 12 and in the left eye was 11 mmHg. Left eye lids show swelling, and in both the conjunctival congestion, circumcorneal congestion was present. The cornea in both eyes show mutton fat capes which were present inferiorly. AC reaction of +1 was seen in both the eyes along with vitritis of +2 grade. The fundus in the right eye showed media clarity grade 2 and the disc was normal size, normal shape, margins were clear, cup disc ratio of 0.2, fovea reflex was present, the blood vessels were within normal limit but were seen hazily, patches of choroiditis was seen, and in the left eye, disc showed disc edema along with the presence of multiple granulomas. So on further investigations, fundus autofluorescence show hyperautofluorescence with surrounding hypoautofluorescence at granuloma sites. Fluorescein angiography showed multiple pinpoint leaks and dye pooling. On further OCT showed multiple pigment epithelial detachments along with serous retinal detachment as seen in above picture. So in OCT picture we can see that there is a large granuloma. On further systematic investigations were done which showed angiotensin levels were mildly elevated. Montox was found to be negative. Zn stain was negative for acid-fast bacilli. The chest X-ray and CT were within normal limit. No pulmonary infiltrates were seen. So based on the bilateral granulomatous uveitis, serous retinal detachment, bacillary layer detachment, absence of infectious signs, a diagnosis of incomplete VKH disease was established. So, after starting patient on oral steroids, oral and topical steroids, OCT showed complete disappearance after 2 days of posterior pole granulomas that were present initially. This spontaneous remission highlights the unpredictable nature of VKH. So, the key differential which were kept in mind were VKH disease, sarcoidosis, and tuberculosis. A VKH disease is always bilateral and the granuloma type is non-caseating diffuse, and OCT finding we can see bacillary layer detachment which and the systemic signs includes vitiligo, tinnitus, alopecia, and they will respond well to corticosteroids. Further, the differential that were kept into mind was sarcoidosis. It can be bilateral or unilateral. The granulomas involved are non-caseating granulomas. On OCT finding we can see choroidal thickening and choroidal nodules which is associated with hilar lymphadenopathy and respond well to steroid along with immunosuppressants. Now coming to the tuberculosis, the granuloma type is caseating non-granuloma, differentiating it from the sarcoidosis. The OCT findings show a dome-shaped mass, which is associated with systemic features like fever, cough, weight loss, and respond well to antitubercular drugs. So based on this, the diagnosis of the incomplete VKH disease was made. So the patient was started on systemic corticosteroids plus topical steroids and cycloplegic. Rapid improvement in the visual acuity and resolution of subretinal fluid and granuloma was seen. No relapse was further noted, and the steroids were further tapered under close monitoring. Talking about the weakage disease now, it primarily affects pigmented individual. It's a bilateral granulomatous panuveitis, which is associated with serious retinal detachment, and you can present with a neurologic and cutaneous manifestation. The diagnostic criteria is of international classification, which is further divided into definitive and probable diagnosis and incomplete weakage. So now coming to the take-home message, the choroidal granuloma represents a common manifestation among different inflammatory and infectious diseases. So this case highlights the diagnostic value of multimodal imaging in identifying key features such as blood, PEDs, and subretinal sepsis, which favor weakage diagnosis. The things taken into consideration were multimodal imaging of OCT and FFA, providing a diagnostic information for the differentiation, and timely diagnosis and management lead to the vision preservation in our case. The systemic clinical evaluation combined with the target investigation is the key for the diagnosis of the weakage and the timely management. Thank you.
So any questions for Dr. Bagla? Any questions more? Thank you.
Thank you.